No, thank you very much, Alexander. We have to move on. I can quote the next paper, actually, the cystic pancreatic incidentaloma presented by Rebours.
Thank you very much. So first, before to begin, I would like to thank Peter for this very nice invitation and to congratulate you for this Hungarian group. I think you do a really great job, you and your team. So thank you very much. So I came 4 years ago, and I'm very happy to be back here in Budapest. So it will be a little break. We will talk about cystic lesion. I know that it was a pancreatitis session. So we'll talk about cystic pancreatic incidentaloma. It's very difficult to pronounce for French people. So let's talk first what we can find in the literature and the prevalence regarding the different organs. And we can see that the pancreas is in the 6th position. And unfortunately, regarding the rate of malignancy, he's as usual at the 1st position. But I'm not so sure that the prevalence we can see here is the real reflect of the reality. So when we, it depends on what we define as incidentaloma and cystic incidentaloma especially. So when we looked at these series studies, which was performed in the general population in Germany, and they perform MRI to people without any specific pancreatic disorders. And what they found is that we can find cystic lesion in probably half of the population. If you assume that a cystic lesion is a lesion more than 2 millimeters, so it can be, of course, discussed and debated. But so this little cyst can be assumed to be cystic pancreatic incidentaloma. So it means that probably the half of the population here today has some cystic lesions. So don't be afraid, we will talk about that just right now. But when we look to the different data of this study, mainly there is 1 to 5 cysts we can find in more than 80%. And we can find that it's very little cystic lesion because in the main population, more than 90% of the people, the lesion was less than 1 centimeter. So when we look, we can see that the prevalence of cystic lesion will rise with the age of the population and the size, and there is minimal progress in more than 50% of the population. So pancreatic incidentaloma and cystic incidentaloma especially, it's probably very, very frequent in the general population. So now have a look to the different type of pancreatic cyst. And at the top, of course, there is IPMN. It's a reflect of the people who came for consultation for pancreatic cystic lesion. And of course, at the top, it's IPMN in probably 9 patients for 10. And then after a more rare lesion as mucinous histadenoma and serous histadenoma, and very, very rare cystic neuroendocrine tumor, which is 20% of PNETs, solid pseudopapillary tumor, and acinar cell cystadenoma. So the problem is that some are precancerous lesions, as IPMN and mucinous histadenoma, and some have potential risk of metastasis as cystic neuroendocrine tumor and solid pseudopapillary tumor. So it will be probably the main issue to find some cystic incidentaloma in the pancreas. So here it's a review of the literature of what was published regarding surgery performed for pancreatic incidentaloma. And here we can see that the tumor size was around 1 to 4 centimeters. And the pancreatic incidentaloma was mainly cystic when we look to all the series which were published in the literature. And more interesting, we can see that the most frequent diagnosis was mucinous, peanut, IPMN, of course, and we can find some pancreatic cancer. And the percentage of malignancy was around maybe 20 and 30%. So, but it was surgical series, of course. So here it's a series of a group. We can see that patients who were operated on for a pancreatic incidentaloma. We can see that the half was cystic lesion with malignant, potential malignant in the half of the patient who were operated on. 25% with potentially malignant and 26% was benign lesions. So first I want to just talk very briefly of the very frequent lesion we can find as cystic pancreatic incidentaloma. The first one is pancreatic neuroendocrine tumor, which we can observe a rising incidence here in the US database. And this rising incidence is due, of course, to the improvement of radiological investigation, CT and MRI especially. And the main rising incidence is observed for tumor grade 1. Grade 1, it means that you have Ki67 less than 2%, or MIB1, that's the other name of this biomarker. And it means that you have a biopsy of the tumor. And we can see also that the tumor is mainly localized. So when we find some neuroendocrine cystic lesions, the problem is, of course, to propose a specific management. And in this international study with more than 263 patients with cystic lesion, neuroendocrine cystic lesion of the pancreas, we can see that the risk of malignancy was 15% and associated with the age, the size more than 2 centimeters. Of course, the presence of involvement of nodes and the size of the main pancreatic duct more than 4 millimeters. So that's why the European guidelines and recommendation we were published is that if the lesion is less than 2 centimeters, no symptoms, no sign of malignancy, of course, on imaging features, and grade 1, it means that you have a biopsy and histological, pathological analysis. So you can propose some surveillance. And the main issue is that they did not distinguish solid neuroendocrine lesion and cystic peanut. So it's probably not the same because the part of the tissue is very low in case of a cystic lesion, but they did not make any difference. So the other lesion I want to discuss is mucinous cystadenoma. You know, it's a precancerous lesion with no communication with the main pancreatic duct, mainly found in women, and probably very well, we just don't know about the prevalence of this kind of lesion. So our team, we just published some kind of criteria which can predict the negative value of malignancy. And so just to try not to operate it on all the patients with this kind of lesion. And we can see that patients which have no mural nodule with a very wall thickness less than 3 millimeters, no enhancement wall, there is a negative predictive value of malignancy equal to 100%. So when we look to surgical series, we can see that retrospectively, probably a lot of patients in this series, more than 75% of the patients could be only followed and the surgery could be avoided. So because we can see that lesions were mainly low grade of dysplasia, and the criteria for malignancy were specifically the presence of nodules, of course, and the size of the lesion more than 4 centimeters. That's why the European expert and the international expert propose now some surveillance for this kind of lesion when the lesion is less than 4 centimeters, when there is no symptom, and when there is no nodules. So the other lesion is serous cystadenoma. Here is the main result of the great international series that we conduct with more than 2,600 patients. And we can see that the outcome, it's, we only describe 3 serous adenocarcinomas. So it means that it's a benign lesion and it's very rare to have any invasive lesion. That's why the European guidelines propose just the conservative management, no surgery, and no specific surveillance for this kind of lesion. The single indication for surgery is when the diagnosis is inserted. So now the main point is IPMN. So when I repeat the first data I present you, I mean that probably the half of the general population, adult population, presents some cystic lesion if we assume that a cystic lesion is more than 2 millimeters. So we conduct a series and to try to assess the prevalence of IPMN in adults. And we find that it could represent quite 7% of the adult population. And we can see that there is an increase of the prevalence with age. So it means that, of course, probably IPMN is represent a large part of all the cystic lesions we found incidentally when we perform some imaging cultures. So, of course, we propose a surveillance for patients with IPMN because we know that there is a risk of cancer even if nothing happened during 5 years. Here in the series, after 5 years of follow-up for this series of more than 300 patients, we can see that there is still a risk of malignancy up to 5%. So it means that we have to continue the surveillance. So we know that European experts propose some specific program for surveillance depending of some kind of worrisome features and high risk of malignancy criteria. And then they propose surgery or surveillance regarding worrisome. And if there is nothing, only a specific surveillance, which is a yearly surveillance based on the clinic's biology and, of course, MRI or EUS. So, is it right to propose this kind of surveillance? We know that there is a lot of people with cystic incidentaloma, and probably nothing will happen if it is IPMN, because if you have no criteria of no worrisome or no high-risk stigmata of malignancy, probably the risk of cancer is less than 1% in the population. And if you have some kind of worrisome, the risk is 4% and 50% if we have some high-risk stigmata of malignancy. So just to slide to finish, I want to show you this new entity, which is not so rare when you find it. So it's acinar cell cyst adenoma of the pancreas, which is a non-neoplastic cyst of the pancreas. We can see there is a ductal differentiation, and the diagnosis can be made with a CT and MRI if you find some cyst calcification, peripheral clustered small cyst, as you can see here. This cyst, there is no communication with the pancreatic duct, and there is usually more than 5 cysts in the entire mouth. So, and the last one is the solid pseudopapillary tumor, which is called also Franz tumor. It's a rare tumor, mainly in women, incidentally discovery. Maybe you can have some symptoms if there is some hemorrhage, but it's a tumor which can be cystic, but also with a mixed type with a solid component. And surgery is recommended because there is a low malignant potential, but some of these tumors have some display behavior. So to conclude and to try to propose a landscape of all the different cystic lesions, we know that for IPMN we have a specific program. For mucinous cystadenoma, you can propose surgery regarding the different criteria. For serous cystadenomas, there is no indication of surgery. For neuroendocrine tumor, you can propose a follow-up regarding the grade and the size. For the Franz tumor, no, you have to propose surgery, and then for the acinar cell cystadenoma, there is no specific follow-up or management. So, pancreatic cystic incidentaloma, the main point is that the main importance is to achieve a complete imaging workup, including CT, MRI, and EUS. There is no surgery without diagnosis. There is no surveillance without diagnosis. And what we propose is first to perform CT and MRI. It can be enough just to have a certain diagnosis. If needed, you can propose an EUS and specific tools to have your diagnosis. I mean, EUS if any, or enhanced contrast EUS, or very rarely cell visio if needed. And what we have to keep in mind is that pancreatic cystic lesions are not an emergency of care. So before to do something, sometimes it's good to discuss all together as we do today. Thank you very much.
Nice large study indeed. Any questions, Peter?
Thank you very much. This was really, really very nice talk. So we know that size does matter. So it's 40.
That's what you say.
Yeah. So 40 millimeters. But is there any other factors you could take into account? So if for example, 30 millimeters or whatever, what are the other prognostic factors or maybe scoring system which can drive you to put the patients to surgery?
You mean for IPMN, for example?
Yes.
Yeah, I do agree. I think that all the study regarding natural history of IPMN just take into account imaging feature. And when you look to use the European guidelines, that's what they say. Even if the proposed diabetes, and I know that diabetes can be sometimes a biomarker or probably pre-neoplastic lesion. So what we need and what we try to focus in clinical research is to include the fact that people can be obese, can smoke. And so to have some inclusive predictive value. And it's probably not the same to have 20 years old, to have a lesion which is already 3 centimeters, to be obese, to smoke, or to be 60 years old. But now we did not propose, we did not distinguish all these cases, and we did not include all the other risk factors of pancreatic cancer, especially. And I think we have to propose an integrative score with all the clinical and demographic characteristics of the patient, of course.
Yeah, I think this is what we need, because below 40 millimeters, there are much more IPMN that would go.
And something it's not entirely described is all the past familial history. And it's something that it's not clearly describing all the study. It's different when you have a first degree relative with the pancreatic cancer and this kind of lesion.
The acinar cell cystadenoma, is there anything known about the risk of malignancy? Should we look at that like a serous cystadenoma? Is there no risk?
So what is described is that there is no risk, but it's a really new entity, and there is a pathological analysis. They don't find any mitotic abnormalities. So they did not perform any genetic analysis just to search for, I don't know, mutation and so, but they clearly don't find any data which could suggest that it could have a potential of malignancy. There is no description of malignancy in the literature.
And how were they sure that they were not looking at a residuum of acute pancreatitis with a calcification, and because of the continuous inflammatory, say, reaction to the stone?
Yes,
normal-like formation?
Because there is absolutely no calcification into the main pancreatic duct, and it's very peripheral. With the duct is beautiful when you perform pancreatic MRI, and there is only very small spot, very small, 1 millimeter sometimes, very small cyst, and there is no communication and no sign, ductal sign of inflammation.
It's very interesting. I've seen that a lot, but I always describe this as I've seen that a lot, but I always described it as a residual cyst of an unrecognized episode of acute pancreatitis. You probably you did the same one.
So, you know, sometimes I get a patient which classification in IPMN or chronic pancreatitis, and they know it's very typical of incidentaloma.
I think with regards to the latter, as you analytically pointed out, all the different categories of cysts, but in clinical practice, very often we do not exactly know what type of lesion we are looking at, and we know from morphological studies and also even US FNA studies that we are very lousy in actually, you know, predicting the cyst type. So I find it always difficult to kind of wrap my head around it, how you should do good research then. And secondly, with regard to your question, and I think you gave a very good answer with regards to you have to take into consideration body weight, smoking, whatever age. But what I find more and more of interest, and we see a good outcome, is the relative growth rate. So the change over time. I think that's much, much more important, by the way, in all of medicine, but in particular also cyst growth. So relative growth over time, because we are following these patients, healthy individuals with a cyst. We're following them every year. So we have that parameter of relative growth rate.
Why yearly?
Yeah,
you know my answer, because I think this is complete over-medicalization of a problem that does not exist, only a small fraction of patients.
Yeah, it's one of the criteria of the European guidelines, I mean, the growth of the cystic lesion. And I do completely agree with the cystic lesion, which is 5 millimeters, for example. We just don't have usually an exact diagnosis to be certain sometimes. So, yes, for this very small lesion, it's quite difficult.
Sorry.
Yeah. How can we develop a Hasblad or Chad-RASC score for cysts? So balancing the risk between treatment, over-treatment, under-treatment.
So it's a question how to do that. I think to answer this question, we have large cohorts. I mean, not 1,000, but 10,000. And we have to, I think, to propose European international cohorts. You know, in my unit, we manage 800. So it's, and if we all collect all the data, it will be just for IPMN. So it will be easy to not easy, but we have a possibility to answer this question and to assume that we can put also all demographic, general characteristic, and so everything. So
yes, because I think that's a very good question, because I don't know with you, but my unit gets completely overflooded with these healthy persons, and we have to do all these investigations. I know when I was young and in training, we always did US FNA, which I think is a crazy, crazy thing to do, because you only cause harm and you don't. Very rarely US FNA contributes to your differential diagnosis. And in fact, we have a cohort, a Pacific cohort ongoing in Europe. And I think just to, and I think you nicely, it's your study in fact, if we can show that we can discard everybody with a cyst below 1 centimeter to undergo regular follow-up, maybe one time after 5 years, I don't know. And then we solve around 90% of the problem with regard to the follow-up. And if you do every year follow-up in all these patients, it will cost billions of euros in Europe alone. And we should stop with that. It's crazy.
Yeah, absolutely. But I think that too, because all the patients are afraid. You say pancreas, they are still they have a craze of anxiety. So if we can integrate all the other risk factors, just to try to have a very more predictive value of which kind of patient we have to propose a follow-up, and this one we can definitely stop. So could help that the patient accept. Because when you have to a patient and say, we will stop now, say, oh no, please continue. So I don't know for you, but it's crazy, and it's a problem of economical problem.
You touched on something I was going to mention, is that there needs to be clear, consistent messaging, because we get patients referred to us that are terrified, and for us to say, well, it's nothing, they can't believe it. And so there's a lot of education that needs to be done as well.
Yeah.
I just wanted to ask you whether you see any role of different biomarkers from the juice, what you can get from the aspirate, or any role of pancreatoscopy, for example, in IPMN, main duct IPMN, where the patient doesn't want to be operated, or?
So, you know, I'm not sure that we have to be too aggressive with this kind of patient. And when you have, so we do perform, of course, endoscopy and sometimes pancreatoscopy when we are not sure that there is, for example, involvement of the main pancreatic duct, and we have to decide with the Whipple procedure. So I mean, if patient with some comorbidities, and so okay, but so in general, patient with IPMN, so this kind of procedure to collect some pancreatic juice, and so it's not something I think to do. And for biological markers, I mean, in the serum, for now there is no really predictive biomarker which can be accepted.
Discussion.